Welcome to the deep dive. Today we're taking a deep dive into adrenal vein sampling, AVS. It's a really critical procedure for anyone managing hypertension, particularly, for radiology residents, endocrinologists dealing with those complex cases. Our mission today to unpack how AVS, which, let's be honest, had a reputation for being challenging, has become such a game changer in potentially curing a major, often overlooked cause of hypertension.
Absolutely. Primary aldosteronism, or PA, it's actually more common than many realize. We're seeing it in, maybe 5 to 10% of screened hypertension patients. The real trick is figuring out if it's unilateral disease, just one gland acting up, which surgery can often fix, or if it's bilateral, meaning lifelong medication is usually needed.
And standard imaging doesn't always tell the full story.
That's the key issue. Standard scans, CT, MRI,
Yeah.
they often miss the mark. There's data showing up to a 40% disconnect with what AVS finds.
40%, wow, that could lead to, the wrong treatment entirely.
Exactly. Unnecessary surgery, or worse, missing a chance for a complete cure. AVS is unique. It directly pinpoints where that excess aldosterone is coming from, which then directly guides the treatment decision.
Okay, that importance is crystal clear right from the start. So, for whom is AVS really the definitive test? And maybe just as importantly, when should we sort of hold back? When is it not the right call?
Right. So AVS is mainly indicated for patients where PA is confirmed biochemically, and crucially, they're actually candidates for surgery, especially if those imaging scans we mentioned are, unclear or conflicting. It's also useful in some trickier cases, like, say, a patient with normal aldosterone levels, but a high aldosterone to renin ratio.
Okay, and the contraindications, when do you definitely avoid it?
Well, obviously, if the patient prefers lifelong medical treatment no matter what, or isn't willing to consider surgery. Also, if certain specific conditions are confirmed, like familial PA types I and III or adrenal cortical carcinoma.
Given how vital it is to get this right, the preparation must be pretty meticulous, I imagine.
Oh, absolutely meticulous. Medication management is key. We need to carefully stop certain drugs, mineralocorticoid receptor antagonists, ACU inhibitors, ARBs, often for weeks beforehand.
Why is that? Interference.
Exactly. They can directly mess with the aldosterone measurements, so we substitute with other meds like alpha blockers or calcium channel blockers. Also, an unrestricted sodium diet and making sure potassium levels are corrected above 3.5. And here's something really important for the interventionalists listening. That pre-procedure CT scan is fundamental.
To map things out.
Precisely. It gives a great view of the adrenal anatomy, helps visualize that challenging right adrenal vein. We see it in over 93% of cases on CT. This makes selecting the right catheter easier, improves efficiency, and definitely boosts safety.
Okay, prep is done. What about the procedure itself? It sounds technically demanding. What are the key aspects there?
It is demanding, no doubt. Access is usually via the right common femoral vein, standard stuff there. But catheter and wire selection, that's critical, especially for the right adrenal vein. It's notoriously tricky.
Right. And I've heard about debates around using cosintropin stimulation.
Yeah, there's an ongoing discussion there. Some use it to try and maximize aldosterone secretion during the sampling, thinking it improves success. Others worry it might actually mask subtle unilateral disease. It's not fully settled. But the real game changer, technologically speaking, that's been the rapid cortisol assay, or RCA.
Ah, the quick feedback loop.
Exactly. It gives you results, often within like 2 minutes, telling you if you've successfully gotten a sample from the adrenal vein itself. Cortisol levels tell you if you're in the right place.
And that improves success rates dramatically.
Hugely. Studies show it jumps technical success from maybe a third, like 33%, up to over 90%, which also means fewer attempts, less radiation exposure for the patient. It's been revolutionary.
That precision sounds amazing. Does it open the door for even finer techniques like this super selective AVS I've read about?
It does. Super selective AVS uses tiny microcatheters. It's really for those diagnostically tricky cases. Sometimes the initial AVS might look like both adrenals are suppressed, what we might call a double down result. Microcatheters let us get in even closer, potentially finding tiny microadenomas we missed before. More precise localization.
Let's talk about that anatomy hurdle. The right adrenal vein, especially, sounds like a nightmare.
It can certainly feel that way. It's small, maybe 2 to 4 millimeters. It's short, and it drains right into the IVC. Sometimes it's even duplicated. It presents challenges.
Much harder than the left side.
Generally, yes. The left adrenal vein pathway is usually a bit more predictable, easier to cannulate. So really understanding those anatomical variations is just crucial for the person doing the procedure.
You've navigated the anatomy, got the samples.
Yeah.
How do you actually interpret them to make the diagnosis?
We look at two main things, two indices. First, the selectivity index. We compare cortisol in the adrenal vein sample to a peripheral sample, say, from the arm. If that adrenal cortisol is much higher, maybe twice as high or more without stimulation, it confirms we successfully sampled the adrenal vein. We know we're in the right spot.
Okay, selectivity first. Then what?
Then the lateralization index. This compares the aldosterone to cortisol ratio between the left and right adrenal samples. If one side's ratio is significantly higher than the other, say, more than double without stimulation, that points strongly towards unilateral disease on that side.
That tells you which side is the culprit. Makes sense. What about risks? Any potential complications or limitations people should know about?
Major complications are thankfully rare now, down around 0.6%. But adrenal hemorrhage, basically bleeding, can happen. It's estimated at less than 1% currently.
And more likely on the right.
About 3 times more likely on the right side, yeah, tying back to that anatomical difficulty. The main limitations really are that AVS is highly specialized, needs experienced operators, and protocols can still vary between centers. There's definitely a need for more standardization.
So bringing it all together, AVS really holds its place as the gold standard, doesn't it? It dictates whether someone might be cured with surgery or needs lifelong medication. It clearly demands that meticulous planning, skilled interventionalists, and using these advanced tools like the rapid cortisol assay effectively.
Exactly right. That collaboration between interventional radiology, endocrinology, and the lab, it's absolutely crucial to getting the best outcomes, to unlocking that curative potential.
So a final thought for you listening. Given how profoundly AVS can change outcomes, turning chronic hypertension into something potentially curable, how do we, as a medical community, work to ensure broader access to this procedure, even though it's technically demanding? It's truly life-changing when used appropriately.